Greetings, ladies and gentlemen, and a warm welcome to our esteemed speakers and faculty, as well as all participants to the ASEAN ACHD webinar. Before I go on, I'll just like to check that you all can hear me and see me. Is that all good? Thumbs up? Yes, that's great. So Gita Kandavelu, I'm from the National Heart Institute, Kuala Lumpur, Malaysia, will be your moderator for today's webinar. Really look forward to an exciting exchange of information, sharing of expertise, and really building a strong network among our ASEAN congenital faculty, along with our friends from the West. The title of today's webinar, The Overlooked Issues of Tetralogy of Fallow. Tetralogy of Fallow is really a common congenital defect, but nevertheless, it continues to pose challenges and dilemmas in the management, especially as these patients get older. And to illustrate this, we have two very interesting talks and a case presentation. However, before I start, some housekeeping rules. The Q&A will be at the end of the three talks. Please put your questions in the chat box, and for the Malaysian delegates, kindly scan the QR code for your CME points. Now, our first talk, titled Timing of Redo Pulmonary Valve Replacement. Do we need a new set of criteria? And this will be delivered by a friend and an inspiration, Associate Prof. Lucia Cristinati, who is a consultant cardiologist and an ACHD specialist at the Universitas Gadjah Mada, Dr. Sarjito General Hospital from Yogyakarta, Indonesia. She's also the president of the Indonesian Pulmonary Hypertension Working Group and has published extensively on the topic of pulmonary hypertension. And she has really made a lot of effort and growth in developing not only pulmonary hypertension, but adult congenital heart, the fraternity, and the training for Yogyakarta, Indonesia. It gives me great pleasure to welcome Dr. Chris Dinati. Dr. Chris, the floor is yours.
Thank you very much. Good evening, Dr. Gita. Thank you for the nice introduction for me. Let me share my screen. Sorry. Yeah. Sorry.
Yes, we can see it clearly, Dr.
Yeah.
Chris.
Okay, thank you. Good evening, all participants. And first of all, I would like to say thank you to the Scientific Committee of Asian Adult Congenital Heart Disease webinar that invite me in this very valuable meeting. The highlight of today's session is about one of the late complications of TOF repair, which is pulmonary regurgitation. When do we need to redo the PVR, and do we need a new criteria? Why TOF? Because it is one of the most common cyanotic congenital heart disease. Without surgical intervention, most patients die in childhood with a rate of survival of 66% at 1 year of age and 40% at 3 years of age. And primary intracardiac repair is the treatment of choice for most patients with TOF and results in anatomic and functional abnormalities in the majority of patients as late complications such as pulmonary valve incompetence. TOF includes the following major features, for instance, RVOT tract obstruction, ventricular septal defect, deviation of the origin of the aorta to the right so that it overrides overriding the aorta, but less than 50% usually, then there is a concentric RV hypertrophy. The surgical techniques has evolved over time. However, the principle of the TOF repair are patch closure of the ventricular septal defects, enlargement of the RVOT, relieving obstructed pulmonary flow by resecting of obstructive muscle bundles, and the use of patch to enlarge the pathway from the RV to the pulmonary artery. And in the process, we want to allow normal growth of the RVOT and pulmonary annulus, complete separation between pulmonary and systemic circulation, preserving RV function, and minimize post-procedural pulmonary valvular incompetence. So in here, we basically try to maintain pulmonary valve incompetence whenever possible. The result of the surgical procedure is invariably complicated by the development of a severe pulmonary regurgitation. Long-standing pulmonary regurgitation in this patient lead to chronic RV volume overload and set into motion a cycle of compensatory mechanism that may lead eventually to irreversible RV dilatation and biventricular dysfunction. In addition, the presence of such a large surgical incision on the free wall of the right ventricle acts as a hotspot for circuit re-entry, and this has associated with increased risk of ventricular tachycardia and sudden cardiac death. And as a consequence, a significant reduction in survival is noted approximately 25 years after repair. Another late problems that we can find are residual pulmonary stenosis in all levels, residual VSD, RVOT, aneurysm, aortic enlargement, and also other uncorrected or overlooked problems. During physical examination, particular attention must be given as we can find a wide split in the second heart sound, a low pitch early ending diastolic murmur suggests severe PR, a long loud ejection systolic murmur indicates RVOT obstruction, a high pitch diastolic murmur indicates aortic regurgitation, and a pansystolic murmur indicates a residual VSD. From the ECG, except for a few exceptions, a right bundle branch block pattern is found in repair TOF, even when no ventriculotomy has been performed. The QRS width may also be influenced by the degree of RV dilatation. Solis et al. In a multicenter study in more than 700 patients with repair TOF at a mean age 8 years demonstrated that an older age at TOF repair and QRS duration more than 180 milliseconds were independent predictors of sudden cardiac death. Cardiac imaging plays a pivotal role in the surveillance of patients with repair TOF by identifying and measuring anatomic and functional abnormalities, informing clinical decision-making, and aiding in risk stratification. The diagnostic information in patients with repair TOF is obtained by different imaging modalities used in concert, such as echocardiography, CMR, CCT, Holter monitor, and EP study. The first modality is echocardiography. As primary non-invasive imaging modality in patients with congenital heart disease, echo has some benefits. For instance, echo is a relatively inexpensive, widely available, not associated with exposure to harmful ionizing radiation, and portable. Hence, echo is ideally suited for longitudinal follow-up in this group of patients. However, we face the limitation that is difficulties in visualizing right heart because of restricted acoustic windows and challenge in quantitative assessment of RV size and function and valve regurgitation. A comprehensive evaluation of repair TOF using an echo should cover assessment of any residual RVOT obstruction and its level, cause and causes, and also the severity, evaluate the etiology and severity of PR, rule out any residual VSD or ASD, evaluate RV and LV size and function, assess the presence of TR, any aortic regurgitation and dilatation. A large meta-analysis by Ferrans-Cavalcanti that published a large meta-analysis with more than 3,000 patients with repair TOF show that the 30 days mortality was 0.87%, 5-year mortality 2.2%, and 5-year re-PVR was 4.9%. However, optimal timing of PVR remains challenging. Why? Because a balance should be made between intervening too early and risking complications versus too late, such with no potential for RV and functional recovery, with no late arrhythmia and heart failure. Because of the with repair and based on the report of American Society of Echo, 2 modalities are recommended for evaluation, which are echocardiography that can be done every 24 months and CMR that can be done every 36 months in stable patient or faster in patient with rapid progression in pulmonary regurgitation. But please underline that CMR isn't recommended for routine evaluation and should be used to address the specific question not answered by echocardiography. Several guidelines such as ACC AHA 2008 and ESC 2010 suggested to do PVR in symptomatic patient with severe PR with class of recommendation 1B and 1C. On the other hand, CCS 2009 have recommendation 2 for this patient. Moving to American Heart Association Guidelines 2013, they have listed 7 main criteria and 5 additional criteria. And the 7 main criteria is RV and diastolic volume index more than 150 milliliter per meter square, RV and systolic volume index more than 80 milliliter per meter square, RV ejection fraction less than 47%, LV ejection fraction less than 55%, or large existence of large RVOT aneurysm, or QRS duration more than 160 milliseconds. For symptomatic patients, we only need to fulfill 1 criteria from this listed. On the other hand, asymptomatic patient need at least 2 criteria from the following criteria. We have talked about the diagnostic criteria. Now moving to the therapeutic purpose based on the American Heart Association 2018, PVR by surgical or percutaneous has class of recommendation 1B for relief of symptoms for patient after referred TOF and moderate or greater PR with cardiovascular symptoms not otherwise explained. So this is the algorithm from American Heart Association 2018. The screen box with red circle stated that we can perform PVR in symptomatic patients with class of recommendation 1. Do we still have a room for asymptomatic patient? Yes, we do, but we should fulfill the criteria, similar with the previous slides, that at least 2 criteria have fulfilled to indicate to PVR. How if the patient doesn't show any of the symptoms? We still have to place to the PVR if sustained tachyarrhythmia appeared with class of recommendation 2B. And how if we don't find any sustained tachyarrhythmia? Yes, we still have a room for PVR if there are residual lesions requiring a surgical intervention. In ESG 2020, quite the same with ESG 2010, in this guideline, PVR is recommended in symptomatic patients with severe PR and or at least moderate RVOT obstruction with class of recommendation 1C. What's interesting is that the catheter intervention or CPVI should be preferred if anatomically feasible with class of recommendation 1C. Let me show you the data from the National Cardiac Center Harapan Kita Indonesia in a period 5 years from 2017 until 2021. This table shows that we have 11 patients with repaired TOF with mean age of 4.5 years old for the first operation and 13.9 years old for PVR. And when the data is being collected, the mean age was 17.5 years old. And we use for 11 patients, we use 5 mechanical valve, 5 using bio valve, and 1 with Gore-Tex. And in conclusion, we have talked about the anatomy, diagnostic approach, the indication from different guidelines, and etc. And unfortunately, the timing to do PVR remains controversial. Balancing between too early and too late are depend on the patient. Yeah. Oh. So do we need a new set of criteria? Yes, it could be the answer of this long-term debate. Thank you very much.
Thank you, Professor Chris, for that very comprehensive review of the guidelines and the timing for pulmonary valve replacement. Looks like we have more questions than answers at the end, which is the whole idea of this symposium today. The next talk is a very interesting management dilemma: aortic regurgitation and ascending aortic root dilatation in tetralogy of Fallots. When should we be worried? And the guidelines are also not very clear in terms of intervening in this group of patients. So we are very pleased to welcome all the way from Boston, Dr. Michael Singh. Dr. Michael Singh is the cardiovascular medicine specialist at the Brigham and Women's Hospital and is an instructor in pediatrics at Harvard Medical School, whose interest includes congenital heart disease, connective tissue disorder, and Marfan syndrome. So very interesting combination. He has held many leadership positions as a director in the Marfan's Clinic and in the Boston ACHD program, and is actively involved in clinical trials and has vast publications in peer journal reviews. It's also interesting that Dr. Singh has been actively involved in the writing committee, board exams, and in teaching. It's something that we are also interested in developing, so something to discuss for the future. But for now, he's going to talk about the aortic root and aortic regurgitation in patients with tetralogy of Fallot. So Dr. Singh, I'm very excited to hear the talk. Please.
Thank you, Dr. Gita and MC and the organizing committee for inviting me. Just want to make sure, can everyone see my slide and hear me?
Yes, we can.
Okay, sorry, thanks. So in giving this talk, there's a couple objectives I would like to talk about through the talk. One is defining the scope of the problem, recognizing that tetralogy of flow is a chronic illness with a potential for long-term complications, including aortic dilation and aortic regurgitation, and recognize that the optimal care for these patients requires a multidisciplinary approach. So basically, what should I care about? Why should I care? Who should care for these patients, and how should they be managed? So just going back to how we actually got here, just historically, Nicholas Steno was the first person to describe a fetus heart, which has become known as a tetralogy flow. This was in 1673. In 1866, Dr. Peacock actually described an unusually enlarged aorta in tetralogy heart malformations. And in 1888, Dr. Fallots described the anatomical characteristics of tetralogy flow. About 56 years later, Drs. Blaylock, Thomas, and Taussig first used the clinical Blaylock, Thomas, Taussig shunt in 1944. And 10 years later, Dr. Lillehei in Minnesota performed the first intracardiac repair of tetralogy flow. This was prior to cardiopulmonary bypass. They actually used a donor cross circulation as the bypass circuit. And 50 years after that, we've come to a point where we could actually implant pulmonary valves and aortic valves through a transcatheter approach, which is pretty much a day's surgery where the patients go home the next day. So can we say mission accomplished? We sort of got patients from not having surgery to having intracardiac repair to having transcatheter repairs. Not exactly. So patients still with tetralogy have aortic regurgitation and aortic dilation. And this can become a problem later on in life. And they may have had several operations, so it becomes a dilemma of when we should operate on these patients and how they should be managed. So to define the scope of the problem, we'll look at tetralogy flow. We know that for the pulmonary valve, it's very common to have aortic pulmonary regurgitation. About 20. I think someone's not on mute. Sorry.
Can all of you mute your mic? Host, please mute all the mics. Thanks.
Pulmonary regurgitation is pretty common. Only about 20% of patients have no pulmonary regurgitation. Tricuspid regurgitation is the next most common valve in tetralogy to have regurgitation. That's about 35%. And aortic regurgitation occurs, none in about 80% and occurs in about 20%. And mitral regurgitation is very uncommon. Probably about 5% of patients have mitral regurgitation. So just so we're talking about the same areas, this is a typical parasternal long axis view for echocardiogram. One is the annulus, two is referred to as the aortic root or sinus of Valsalva. In this talk, I'll refer to it mostly as aortic root. Number 3 is sinotubular junction, and then 4 is the ascending aorta. So we know that aortic root dilation and aortic regurgitation is unappreciated comorbidity in tetralogy of flow, but also in other conotruncal abnormalities as well. This can be progressive late after repair. There's one study with about 126 patients that showed about 30% had aortic root dilation, 24% had ascending dilation, and between 12 and 21% had aortic regurgitation that was associated with aortic root dilation. This is a study from the ARC group, or the Alliance for Adult Research in Congenital Heart and Congenital Cardiology. Part of our patients were in this study. There were a total of about 474 patients. They looked at aortic root diameter dilation defined as greater than 40 millimeters. The average age for those patients was about 42, and about 29% of those patients had that. If we looked at the dilation in a different way, as far as the indexed observed to expected ratio greater than 1.5, that percentage is much lower, about 6.6. Out of those patients, about 3.5% had moderate to severe aortic regurgitation. They found that the aortic arch sidedness, so right aortic arch, was not associated with aortic root dilation. There was no significant independent predictors for that. This is another study from the Mayo Group in Minnesota, looking at 453 patients with an average age of about 37. They used echocardiogram, CTA, and MRI, and they defined aortic dilation as based on normative data. So if you look at that way, it was about 51% aortic root dilation, 51% aortic root dilation, almost 70% had ascending aortic dilation, about 9% was progressive aortic dilation. If you looked at severe aneurysms, so defined as greater than 5 centimeters, aortic root aneurysms was about 9%, and ascending was about 9% as well. Fortunately, there was no aortic dissection. Similar to the general population, the incidence of bicuspid aortic valve was about 2%. And out of the severe patients that had aortic valve disease or aortic aneurysm, which is about 52 patients, only about 29 had undergone intervention, and fortunately none of them had surgical mortality. Most of those patients had severe aortic regurgitation and aortas bigger than 5 centimeters. So what should we care about? So if we put these patients into sort of bigger buckets, we can define them as too big, too leaky, too stiff, too elevated, too altered. So too big would be aneurysms, too leaky would be aortic regurgitation, too stiff would be abnormalities in the aorta with aortic stiffness, decreased elasticity. Too elevated would be the biomarkers that we look at, and too altered would be genetic factors. So just to define the normal aorta, so if you remember back to pathology, the aorta consists of 3 layers: the intima, the media, the adventitia. The media is the area where most of the action is occurring, where there's layers of elastic lamellae, smooth muscle cells, collagen fibrils, mucopolysaccharide ground substance, and all these factors work together. So the aortic media is not a static structure. There's some data that the elastin half-life in the aorta is about 40 to 70%. So if we look at just normal patients with increasing age, you could see that they have some abnormalities in the media, decreased and degeneration of the elastic media, partial replacement with collagen, elastic fragmentation, medial necrosis, smooth muscle disarray, and fibrosis. So let's look at the aortic histopathology. So this is 4 different studies where they looked at 4 different disease groups. One is congenital heart disease, aging aorta, bicuspid valve, and then Marfan syndrome. So for the congenital heart disease group, which included some patients with tetralogy of flow, they saw that there was abnormalities in the media of the aorta with the smooth muscle, elastic fibers, and collagen. In the aging aorta, there was also histologic changes in the media that correlated with age. In bicuspid aortic valve, the mechanism seemed to be apoptosis, where there was underlying smooth muscle cell loss in the ascending aorta. And then Marfan syndrome, there was cystic medial necrosis, loss of elastic fibers, and they found that the elastin was more prone to degradation by the MMP than in normal elastin. So if we look at the pathology, these and B are both normal. And then C and D are patients with tetralogy, looking at this slide. So these are patients that were either post-mortem or post-surgical analysis, and they're anywhere from neonates to adults. And in C, you can see that there's loss of or disruption of the elastic lamellae. And in D, the green staining is fibrosis. There's a lot more fibrosis in these patients. And in the study, they found that there was almost 80% of lamellar loss, almost 60% of elastic fragmentation, and almost 82% of patients had fibrosis. So too big or aneurysm. So what are the risk factors for having aortic root dilation in tetralogy? So some of the studies suggest that pulmonary atresia is a factor, the time interval between palliation, palliative procedures, and corrective repair. Some studies suggested that 22q11 deletion syndrome was involved, others didn't. Others felt that right aortic arch was involved, some others didn't. But we know even with non-congenital heart disease and acquired heart disease that older age, male gender, smoking, and hypertension are all involved in aortic dilation. Fortunately, we haven't seen much aortic dissection in patients with tetralogy of flow. And actually in the medical literature, there was only 5 studies that reported aortic dissection in tetralogy of flow, and they were from different areas of the world. Nothing was in one particular area, so you would suggest, if the surgery was different. Most the patients age range from 18 to about 60, and they were pretty big aortas. So the largest was 9.3 centimeters, and the smallest was 5.5 centimeters. Most of the patients survived the dissection, and they all had various types of repair, mostly the Bentall operation. So the question comes up whether tetralogy of flow patients have intrinsic connective tissue disorder, or is this just the intersection between tetralogy of flow, which is about 1 in 3,600, and other connective tissue disorders. So for Marfan syndrome, it's about 1 in 5,000, or other things like Loeys-Dietz or vascular Ehlers-Danlos syndrome. None of the studies described any of the phenotypic features of the patients to suggest whether they actually had a combination of tetralogy of flow as well as some other connective tissue disorder associated with their dissections. Pregnancy and aortic dilation. There was a study with 19 women that went through pregnancy. They all had cardiac MRIs. Fortunately, there was no pregnancy effect on the aortic root geometry. There were small increases in the diastolic dimensions, and this may be related to hormonal changes and also the increased volume that's associated with pregnancy. Too stiff. The mechanism of aortic dilation. There's abnormalities we know in the ascending aortic wall. We know from histopathology there's cystic medial degeneration. This seems to be at a lower grade and distribution than in Marfan syndrome. There's also physiologic, hemodynamic, and genetic factors that may play a role. And there's some thought that maybe the early chronic volume overload of the aorta prior to repair due to the primary right to left shunting causes some enlargement of the aorta itself, not necessarily large and thin walled, but just large just to compensate for the extra volume. The abnormal flow conduction is similar to the aortopathy in bicuspid valve as well. And the increased aortic stiffness also correlates with the degree of dilation in these patients. This was a smaller study looking at 16 patients after pulmonary valve replacement. The average age was 31. They had a little bit larger aortic roots than the normals, and they found through echo data that there was reduced aortic elasticity and reduced aortic root distensibility. And this was associated with only minor degrees of aortic regurgitation, and the aortic wall pathology may represent a separate mechanism leading to some of the patients that we see have left ventricular dysfunction. There's MRI data using 4D flow MRI, which is involves 3 directional velocity encoded phase contrast. And they found that there was increased aortic wall shear stress and stiffness and abnormal flow. And this was despite having normal dimensions. So there may be some preclinical factors that we can look at for before patients get aortic dilation. There's a lot increased energy loss, and this may contribute to some of the left ventricular function and volume abnormalities that we see. It may be associated with abnormal left ventricular outflow tract geometry and the ventricular interactions in patients that we see with tetralogy of flow. They had lower aortic elasticity by tissue Doppler, and this had a negative effect on the left ventricular diastolic function. To leaky or aortic regurgitation, again, this was another study with 72 patients looking at cardiac MRI, and they found that most of the dilation at the sinotubular junction and the ascending aorta were stronger predictors for aortic insufficiency than aortic root dilation itself. To elevated, which are the biomarkers. So there's been studies performed in Marfan syndrome where they looked at excess TGF beta, and that seemed to cause some of the phenotypic features of Marfan syndrome. They also looked at patients with tetralogy to see whether excess TGF beta 1 causes problems. And this did show that when there was excess TGF beta 1, there was excess levels that promoted tissue fibrosis. This also correlated with the diameter of the ascending aorta in repaired patients. And this is without treatment with ARBs. It's still unclear whether treatment with angiotensin receptor blockers can prevent aortic dilation, which has been shown in some studies with patients with Marfan syndrome. This is another study looking at TGF beta signaling, and they found that altered TGF beta signaling may increase production of the MMP proteins 2 and 9, leading to the matrix degeneration in the aortas of patients with tetralogy of flow. And you can see here, TGF beta, MMP2, MMP9, all three of those were statistically significant compared to controls. And when you look at Fontaine patients where we also see some dilation, it was only the MMP2s that were involved. And for TGA with arterial switch, there wasn't any significant change between the controls and those patients. To altered the genetic variants and aortic dilation, there was a study that looked at 74 patients who underwent intracardiac repair. And what they did was look at the aortic tissue and also did venous blood samples. They found that only about 21% of the patients had normal histopathology. About 70% had aortic dilation, and most of the patients with dilation had abnormal histopathology. They also looked at fibrillin 1 in the exons 24 to 28, and they found that 51% of patients had sequence variations in that area. Not necessarily meaning they had Marfan syndrome, but just had a fibrillinopathy that may be contributing to the aortopathy in this patients. There was also a polymorphism analysis, which showed there were a significant amount of patients that had that. And they felt that the risk of aortic dilation was about 8.8 times greater with histopathological changes and 8 times greater with patients with a fibrillin exon variants. So how should they be managed? Medications, cross-sectional imaging with CT scans, MRI, echocardiogram, surgery, or do we have transcatheter options for these patients? Monitoring of these patients, we typically do cross-sectional imaging every 3 to 5 years. Some patients are more frequent if we don't have good echo images, or they're growing faster and we want to keep on top of how fast they're growing. Measuring the aortic dimensions, the degree of aortic regurgitation by echocardiogram, and also looking at aortic regurgitation fraction, which we can do by MRI, and looking at ventricular size and function. Other things that aren't typically done, but maybe in the future, this may be helpful for preclinical management, is looking at aortic stiffness with either MRI or echo, biomarkers, and then genetic markers as well. We know that in patients with aortic root dilation and Marfan syndrome that angiotensin receptor blockers may decrease the rate of growth. In those patients, there have been several studies that suggested that. This hasn't been the case for patients with tetralogy of flow. This was a study with 60 patients where they randomized them to losartan versus placebo and treated them for about 2 years. So it wasn't a long period of time, and it may not be long enough study to actually show any improvement, but there's no strong support for the use of beta blocker or angiotensin receptor blockers to decrease the aortic root growth rate in patients with tetralogy of flow. So what factors do we use in the decision to intervene? So similar to other diseases is the aortic growth rate. So if patients are very stable, we tend to continue to monitor them, or if they have a very fast growth rate with 5 millimeters a year or more, then we consider doing intervention at an earlier time. We also look at the risk of the morbidity of the procedure for elective procedure in these patients. Other comorbidities, as patients get older, they may develop coronary heart disease, diabetes, and other things that may make the risk of the surgery much higher. Family history. So if there's a family history of people with aortic aneurysms or dissections, then we may look at that as a factor of when we would do the repair, maybe at an earlier time, and then other genetic risk factors, and also to protect the left ventricle, especially with patients that have left ventricular dysfunction that may be related to early repairs and aortic regurgitation with left ventricular dysfunction. For surgical repairs, this was a study that looked at 236 operations out of 4,000 patients. The number of patients that went to surgery for aortic regurgitation was pretty small, about 8.5%, and for aortic dilation, even smaller percent, about almost 2%. The operations for the aortic root were infrequent. The surgical repair risk was high, given that some of these patients had multiple reoperations, and they found that the larger the ascending aorta diameter was, it was associated with early mortality, and most of the mortality was related to low cardiac output, and several patients had intracranial hemorrhages as well. So the indications for aortic root and valve replacement shouldn't be too much different than the general population. It doesn't look like they have the same aortopathology as Marfan syndrome, where we would do surgery at an earlier time. And this should be based on the clinical data, comorbidities, associated anomalies, life expectancies. In general, we start thinking about it when the aorta is greater than 5.5 centimeters, or if there's a very fast aortic growth rate. And the procedures that are used are the traditional Bentall type procedure, or some patients, if the aortic valve looks like it's in looks well enough to be able to do a valve-sparing aortic root replacement. Some of the management decisions. So medical management, we're aggressive at treating patients with hypertension. If patients are prohibited for surgical risk, we may treat them medically with ACE inhibitors, angiotensin receptor blockers, or newer medications like Entresto. For surgical management, if patients are symptomatic with aortic regurgitation, that would be an indication. If they're asymptomatic and have severe aortic regurgitation and have a low ejection fraction, less than 55%, that's an indication as well. If patients have severe aortic regurgitation with other indications for cardiac surgery, meaning they have to have a surgical pulmonary valve replacement, they would do the aortic valve at the same time. Some other indications that are reasonable to do, but not class 1 indications, are patients that are asymptomatic, severe aortic regurgitation, normal left ventricular function, but severely dilated left ventricle, or if they have moderate aortic regurgitation and there's another indication for them going for cardiac surgery, then that may be reasonable also, as well, to proceed with aortic root or aortic valve surgery. So what's in the future? It's been 50 years between having the initial intracardiac surgery and transcatheter valves. Now, what's going to be in the future? Who knows? Could it be gene editing? Could it be 3D printing of cardiac structures? Only the future will tell for that. So in summary, what should I care about? Patients with tetralogy flow, we all know have pulmonary regurgitation, but we should also look on the left side for aortic dilatation, aortic regurgitation, some of the other factors that may be helpful to to look at our aortic stiffness biomarkers and genetic profiles. Why should I care? These patients have a chronic illness. They're not cured despite the surgeries that they've had performed. They continue to have morbidity and mortality, including heart failure. And this may contribute to a multifactorial process for left ventricular dysfunctions in some of the patients that we see with tetralogy. It can help improve their exercise intolerance and improve their survival. So who should care for these patients? How should they be managed? Our approach is to use a multidisciplinary approach. So for patients that are complex, we have a once weekly conference where there's the surgeons, adult congenital cardiologist, pediatric cardiologist, interventional cardiologist, cardiac anesthesia, electrophysiology, all there. And we discuss all aspects of the patients. They continue to need careful monitoring, not just for the right side of structures, but also for the left side of the heart as well, and referral to appropriate centers for complex interventions if they're needed. So not all tetralogy patients are the same. Everyone should be treated as an individual. There's no one size fits all. So all the data that we use are individual based on what that particular patient has. And they should be, the management should be tailored for the unique features of each patient. So thank you for inviting me. And if you have any questions.
Thank you, Dr. Singh, for that very, very comprehensive review of a difficult topic. We will move on to the case presentation, and like any webinars, the icing in the cake is always the case presentations, because this is when we put our knowledge to good use. And for today, Professor James Yip, my dear friend and mentor, is going to share an interesting patient with us. Professor James Yip is a senior consultant and associate professor at the NUS Yong Lu Lin School of Medicine. He is also the current medical director of the National University Heart Centre in Singapore. He's one of the pioneer ACHD consultant in this region and has played a big role in developing the ACHD fraternity in Singapore, and also inspired many of us to follow suit. So it gives me great pleasure to welcome Dr. James Yip. James, please share your case with us.
Thanks, Geeta. Let me just get my slides up. Okay. So this is in following up with Michael's talk. In a sense, I'm not really going to dwell very much into my case presentation, but I'm going to give you two cases which I've seen over the years, and then talk a little bit about this interesting problem in tetralogy of Fallot, which is predominantly perceived as a right-sided heart disease. Now, the first case is actually a straightforward case, but also complicated at the same time. This was a 17-year-old boy when I first saw him. He had a tetralogy of Fallot repair, a transannular patch in 1996 with resection of the infundibulum, as well as closure of his VSD at age 7. But post-op, he was, he had this chronic atrial flutter, and he was beta blocked. And at that point of time, EP services weren't very developed in Powell, anticoagulated. And then he suddenly disappeared for many years until he showed up to see me. When we first saw him, he had dilated RV, LV. He had moderate reduced RV function, and he had severe LV dysfunction. His CF was only 20%. And we presume that it's mainly due to tachycardia-induced cardiomyopathy. He had severe TR and significant severe PR as well. So when we first saw him, we initially TE'd him and then cardioverted him, and then rate controlled him and restarted his anticoagulation. So after 6 months of that, he had improvement of his LV function, and this was on echo with improvement of his LV function to 50%. So that was a good start. And he did the same thing again to us. He disappeared after that for many years, and then he reappeared with atrial flutter again in 2013, and this time we did an atrial flutter ablation on him. He had a recurrence of this persistent atrial flutter in 2014 and had a second ablation. Over that period of time, he had progressive RV enlargement with reduction of his RV function in 2018. And finally, the decision was made to replace his pulmonary valve using a minimally invasive approach with a valve prosthetic 25 perimile magma ease. So this is just a representation of the events that occurred in this young man with MRI data and CPAP. I decided not to put the echo data because the problem with echo, as we well know, is that it's very hard to assess RV function and RV volumes, as Chris Donati had explained to us. We also show the utility of using cardiopulmonary exercise testing in also making this decision as to what to do with him. So as you can see, his main problem was that of tachycardia-induced cardiomyopathy when at his first presentation as a young person, and you can see the effect of cardioversion as well as atrial flutter ablation that, his left ventricular function improved after rate control. But over time, as you can see, his cardiopulmonary exercise testing parameters, his VO2 max was at its best in 2015. And then you can see a drop in his VO2 max from 2015 to 2018. But if you look at the MRI parameters, you can see that although his RV was more dilated over time, it didn't reach the usual parameters that we would look at, which is about 150 cc's per meter squared for pulmonary valve replacement. However, his right ventricular ejection fraction did fall, and his LV ejection fraction was still preserved. It was because his exercise capacity fell with symptoms and with right ventricular ejection fraction dysfunction that we decided to replace his pulmonary valve. So he had a reasonable outcome. However, post-surgery, you can see that 2 years post-surgery, his LVEF again became a low normal number, and this is when we decided to give him a very low dose angiotensin receptor blocker to look at this issue. Okay, so a lot of these tetralogy of Fallow patients, you can see that the RV function, I think MC put a little note in the chat to say a lot of these patients, their RV ejection fraction don't really improve very much after procedure, and left ventricular ejection fraction also may not improve very much. This is a second case, which is a little bit more in the vein of what I was going to talk to you about today, is a patient who on onset had, again, a transpulmonary patch, transannular patch in 1989. He had severe PR at the point of presentation with a regurgitation fraction of 45%. Already at his first MRI, it showed that his RV was severely dilated, his RV function was poor, and his LVEF was also not good. So this at first presentation, he did his cardiopulmonary exercise testing, and you could see that his functional capacity was not very good. So we sent him very early on for an aortic valve graft at age 21. So you can see this young gentleman followed up over time with serial MRIs since his surgery that even after pulmonary valve replacement, this gentleman, his right ventricular ejection fraction only improved a little bit. And in 2020, it actually came down a little bit. His left ventricular ejection fraction again was not improved very much after surgery, and the decision was made for this young man to start on angiotensin receptor blockers, and you can see that there was some marginal improvement in his ejection fraction. So I just wanted to talk about this before we can discuss the two cases again, if you're interested. That the tetralogy of Fallow is both a right and left heart disease. And this is inspired by my friend Erwin Oshelin, who wrote this little review article. It was very, it was actually noted many years ago, this effect by Hippolyte Bernheim of this problem called ventricular interdependence. In his first description of this, we're probably in patients with severe aortic stenosis, where severe dilatation and hypertrophy of the left heart started to compress the right ventricle. And this was showing that the left heart had effects on the right heart, and this was called the Bernheim effect. Of course, in our group of patients with adult congenital heart disease, we see the opposite, which is a reverse Bernheim effect, where a large dilated hypertrophic right ventricle may indeed affect the left ventricle. And hence, he is often known as the father of ventricular interdependence. The mechanisms of LV dysfunction and tetralogy of Fallot is actually multifactorial and very poorly understood. We realize that this disease is not just a systolic dysfunction disease, but also a disease of diastolic disease dysfunction. Often there's tissue injury, diffuse fibrosis due to early cyanosis in these patients, intraoperative hypoxia at the time of surgical infection, or maybe even coronary artery disease. Another potential mechanism, as we were already alluded to, is ventricular-ventricular interaction. And this occurs because both ventricles share the same myocardial fibers, the septum and the pericardial space. And often, as you've seen in the first case presentation, arrhythmias, dysynchrony due to conduction disturbance, and RV pacing may also cause LV dysfunction in this population of patients. So this was a paper that my friend and colleague and mentor at the time, Judith Terrien, when I was a fellow at Toronto General Hospital, showed that, the left ventricle is indeed a risk factor for sudden death in adults late after repair of tetralogy of Fallot, with the curves, Kaplan-Meier curves separating really early on. This group of patients which had sudden cardiac death at a higher risk of having syncope, ventricular tachycardia, alluded to by Chris earlier, QRS duration that's more than 180 milliseconds, as described by Michael Getzoulas. These patients also, 50% of the time, had moderate to severe LV dysfunction and significant pulmonary regurgitation. In this Italian series, it tells you that about 1/4 of post-tetralogy of Fallot repair patients have left ventricular dysfunction. And this is mainly in the male patients. These groups of patients have large left ventricular end diastolic volume. They also have poor right ventricular ejection fraction. They have significant late gadolinium enhancement in both the right and left ventricle. And the LV dysfunction correlated with RV dysfunction and the late GAD enhancement. In this other series from Rickers et al., he again showed that in this 70-odd patients, poor LV dysfunction correlates with RV thinning, which is a representation of scarring in the right ventricular wall, higher RVN systolic volumes, RV mass index, as well as poor ejection fraction, and is as similar to our patient earlier on, low VO2 max. Often the systolic dysfunction doesn't stop there. There is also diastolic dysfunction. And in this series in 2012 from Mark Freeberg, it showed that these patients had lower LVN early diastolic radial and circumferential strain rates on tissue Doppler. And these lower strain rates were associated with greater RV volumes, greater pulmonary regurgitation in these patients repaired with tetralogy of Fallot. Again, similar to what Michael showed earlier about 4D flow mapping on MRI, he showed the upper part in the aorta, but this is in the left ventricle. As you can see, compared to control groups, patients post-repair still have very abnormal diastolic flow patterns. In the control group, you can see that these patients with repaired tetralogy of Fallot with mild to moderate RV dilation have abnormal LV diastolic direct flow. They have increased recirculating residual volume. And of course, these changes correlate with the degree of RV dilation and impaired LV function. And so despite the fact that we have repaired the pulmonary regurgitation in this group of patients, these patients go on to have significant LV diastolic dysfunctions, which may actually explain why some of these patients do not get better after surgery. The LV does not get better. Again, these patients, if you want to look at left ventricular systolic dysfunction as well as a meta-analysis of their outcomes. This is in seven studies over time. And in this meta-analysis, it showed that there was a 30% increase in cardiovascular adverse events, which includes death, aborted sudden cardiac death, or sustained ventricular tachycardia in these groups of patients. So there's a 30% increase in these events for every 5% decrease in the left ventricular ejection fraction, which tells you that every percentage point for left ventricular function is important in preventing these patients from having these adverse cardiovascular events. And of course, LV systolic dysfunction and RV systolic dysfunction have approximately the same magnitude effect on the incidence of adverse events. So the clinical implications of everything that I've talked about is that the presence of LV systolic dysfunction is indeed a soft indicator to support early pulmonary valve replacement in patients that has already other indications for pulmonary valve replacement. So following pulmonary valve replacement, LV filling and systolic has been shown to improve in some patients, but in not all patients, like in the ones that I've demonstrated in my case presentation. There is a statistically significant but not clinical significant improvement in LVF by 2 percentage points after pulmonary valve replacement. And often this is due to increase in LV end diastolic dimensions. MRI can look for these LV late gadolinium enhancement. It can also look at the diastolic LV abnormalities that I've shown you earlier, as well as tissue strain Doppler. And again, in evaluating a patient for pulmonary valve replacement, I think that these are the open-ended questions that perhaps we should also look for these markers in deciding whether patients should have an earlier PVR. And of course, for drugs usage for LV dysfunction, do we use the established LV dysfunction medications that are prevalent for the adult group of patients, which includes your ACE inhibitors, angiotensin blockers, and Entresto, and then more recently, the SGLT2 inhibitors are very sick one. And of course, cardiac resynchronization therapy for the really broad right bundle branch block that we see in this group patient. This is work done from a European and Canadian group with my friend Louise Harris. It showed that in this 14 patients with tetralogy of Fallots who had cardiac resynchronization therapy for right bundle branch block, that these patients were all done for impaired LV function. CRT seems to be effective in improving the systolic ventricle, as well as the New York Heart Association score for these patients quite significantly. So in conclusion, tetralogy of Fallot is both a disease of the right heart and the left. LV dysfunction in impaired tetralogy of Fallot is common, up to a quarter of these patients, and is of course prognostically important. The causes are multifactorial, and of course, comprehensive assessment of the left ventricle is an important factor in this group of patients as well. So not forgetting the left when we look at the right. Early PVR is important and may preserve LV and RV function. And of course, we have to always look for opportunities to treat the LV dysfunction, although the evidence for a lot of the drug therapies which have been used is not quite there. So in summary, we have to look to the left to get it right. And I think my friend Erwin Oshulin was indeed correct.
Yes, thank you, James, for highlighting another area that most times we do not really pay enough attention to, and also much lacking in terms of the guidelines about the timing and the review and the investigations. So now we are open for questions. We have had a very comprehensive review of tetralogy of Fallot, looking at timing for pulmonary valve replacement, looking at the aortic root and AR, as well as the left ventricle and arrhythmias that was brought into discussion in the first two patients. So I'm going to go through, there are some questions that are in the chat group. And I think the simple question for most of us is on our review of these patients with tetralogy of Fallow, we tend to do ultrasounds and echocardiogram because that's the standard that we do in our clinics. It's easy to do, it's cheap, and it's reproducible. However, the main challenge faced is assessing the right ventricular function. Yes, we can do MRIs maybe as a baseline, maybe once in a few years, but it is an expensive test. So I'm going to open to first to Dr. Chris and then to the rest of the faculty members with regards to how you can use the echo to assess the right ventricular function, and how reliable or what parameters do you use in your day-to-day practice. So I'll start with Chris. Chris, maybe you can share some information about echocardiogram in assessing the right ventricle and in post-stop repair.
Yes, thank you, Dr. Gita. And thank you to Dr. Anissa for the question. Yes, there are several measurements for RV systolic function. Like Top said that we very familiar for this measurement, and also RV fractional area change, also with S-accent, and also with RV MPI, and also with GLS, RV GLS. Yes, but for TOF, for indication, whether the patient needed to PVR or not. So this criteria is using RV and diastolic volume index, and also right ventricle and systolic index. So in case if the RV and diastolic volume index is more than 150, and also RV and systolic volume index is more than 80 milliliter per meter square, so this patient is needed to perform PVR. This is two of the criteria that used for criteria for PVR.
Thank you, Chris. I'm going to ask Dr. Michael Singh. What are the echo parameters that you use in following up these patients in your day-to-day practice?
Yeah, we use the basic things that we use for all patients from that standpoint. We also look at the mechanism of the tricuspid valve regurgitation, because a lot of these patients either have primary tricuspid valve issues or there's dilation, and we think that maybe the papillary muscles get pulled apart, causing some of the regurgitation. We found that even with either transcatheter valve replacement, isolated doing the pulmonary valve, or with surgical, it doesn't really decrease the degree of tricuspid valve regurgitation as much as we would like to see. So most of the surgeons here do some operative repair on the tricuspid valve itself, either at the leaflet level or try to pull the papillary muscles a little bit closer together. There's from what I've seen, we don't have a lot of sort of research things that's published yet from that standpoint as far as sort of novel things, but we're pretty heavy use of MRI here. But I agree, like it's very expensive. It's getting harder and harder for insurance to improve it. So I think we need some other way to be able to gauge these patients, because some patients is prohibitive from their insurance to even get it, and then we're sort of stuck about how we should manage these patients and whether there's other factors that we can use to do that. Hopefully in the future we can do studies to be able to pull that together.
James, how about you? In your echo lab?
I'll be honest with you that I find echo very inconsistent in being able to gauge RV function and volumes, and even LV function. I was looking at my patients that I presented just now, and the LVEF of these patients, especially even after tetralogy of Fallow repair, just keeps it can be any number that you pick from 40 to 55, and I find it difficult. But I agree, Michael. It's good at looking at the other valves that may also contribute, like the aortic valve as well as the tricuspid valve, which is is useful when you want to look at these other parameters, which MRI is not particularly good at. So, I use quite liberally the MRI, but as everyone has pointed out, it's hard and it's getting expensive. Yeah.
So I think one of the important things that we have learned is that we are limited in terms of using MRI that will give us the value. So we are day-to-day practice is using echo, but trending, I think, is an important parameter. So maybe trending the patient and monitoring the patient over time. Again, I think the tricuspid valve and regurgitation is an important factor to be taken into consideration. And also, as you mentioned, the LV-RV interaction in terms of getting accurate results. But I want to ask, what about the role of using exercise testing and biomarkers in guiding in terms of the deterioration of the patient or the progression of this disease? James, since you are on, can you just give your input on that?
I was trained by the late Gary Webb, who told me that my congenital patients, or rather his congenital patients as well, almost never complain of exercise intolerance at all when you ask them in the clinic. And so clinical history is not very reliable. And so in our labs in Toronto, we did a lot of cardiopulmonary exercise testing, with a practice which I've carried when I've come back to Singapore. And as you can see from the first case illustration, this patient particularly had a significant drop in the 3 years in between that we saw him. And even though the MRI parameters were not so significantly worsened, it was enough for us to warrant a PVR in this group, in this particular patient, because we felt that we did not want to wait any longer. So biomarkers, no, we use that a lot for pulmonary hypertension, but we don't have much experience using NT-proBNP and things like that as a decision maker for tetralogy of Fallot.
So Michael, what about your thoughts about using biomarker and VO2 max as a guide? Because like I say, we can't do MRIs frequently, so we need to look at other more practical and cheaper ways to assess this patient.
Yeah, we as well use the CPETs or with the metabolic cart to look at the VO2s. Some things that we find in some of our older patients, as they gain weight, it looks like, the VO2 goes down if you correct for the weights. We also look at the absolute values as well, just to make sure we're not just basing it just on that. Some of the patients could go down to, VO2s at 10, when if you look at the absolute values, it's similar to what it was on the previous years. And also trending, like you had mentioned, not looking at one value. Like if you look at 5 values over, 10 years, it may, from the first and last year, may look relatively the same, but if you look at 3 in the middle, it looks like they're declining. So it's also looking at the trend over time. As far as biomarkers, we tend to get things like the NT-BNP to see if there's any sort of preclinical things that we can find where by our physical assessment, we don't see much volume overload, but maybe there's something preclinical that we may see that may guide us to be a little more aggressive with either diuretics or procedures from that standpoint. And if we're not sure, we tend to cath to get hemodynamics just to see, so we're not missing anything.
So Chris, the question now, the $1 million question is timing of pulmonary valve replacement in this group of patients. And I know the guidelines have all focused on volume loads and MRI, but more and more we are seeing data that is showing that just absolute volumes, that with the index volumes, does not translate to mortality long-term and RV function improvement. It may improve functional class, the volumes may drop or remodel, but not necessarily long-term improving survival and RV function. So what are your thoughts about the guidelines with regards to just using the RV volume index for both systolic and diastolic index? Should we be more aggressive to look at other things that were mentioned today, like the left ventricle, or maybe looking at focusing on right ventricular function or RV mass, maybe more hypertrophic, increasing mass? What are your thoughts?
Yes, thank you, Dr. Gita. Yes, based on the guidelines, there are several criteria for determining whether this patient can indication for PVR or not. Not only RV end-diastolic volume and systolic volume, but other parameters can be used. In case that the RV volume is still good, so we have to see the other parameters like LV ejection fraction, RV ejection fraction. Is there any aneurysm or ECG? Is there any arrhythmia or not? And also the QRF duration is more than 160 or not. So if they fulfill one of the criteria in symptomatic patients, so this indication for PVR, but in case that still asymptomatic, so we need at least 2 fulfill criteria, not only the RV volume index, diastolic or systolic. That's
So, thank you, Chris. So I also have a problem because the timing of, when you have adolescents, you find that for many years, the RV volumes remain about the same, and then it progresses slowly. So how low do we go? Now they talk about pulmonary valve, transcatheter pulmonary valve replacement following pulmonary valve surgery, right? Replacement. So people are talking about lower and lower volumes like 150 or even more. But you're looking at adolescents, and then you have to strike a balance. So what are your thoughts? Should we stick at 160 as the guideline says, or should we not really just go with volumes and just go with other parameters? What are your thoughts?
Yeah, the guidelines said that that not only the volume, but we have to look the other parameters to see whether this patient needed to intervention or not, and not the parameter from MRI, but also from other parameters about the arrhythmia or about the ejection fraction and so on. Dr. Gita.
Maybe James and Michael, because we have a dilemma. We see patients during adolescence for many years, at least for 5 to 10 years, the RV volumes are same, but they are like 150, but they are same. And if you go and replace the valves early, then you're putting this patient at risk of multiple reinterventions. So as they get older, it becomes easier to make the decision. So what are your thoughts about these values, these absolute values, or how would you approach these patients?
Yeah, so a lot of these patients also have diastolic dysfunction, so you may not see the dilation that you would typically want to see as they get older. So it makes it more difficult because you have this false sense that, oh, the ejection fraction is the same, the size is the same, we should just watch them. But then over time, they still have, pretty severe pulmonary valve regurgitation, and then sometimes you see some antegrade diastolic flow, especially on MRI, that suggests, okay, they're getting a little bit stiff. And unfortunately, there's not much medication that you can use to sort of help relax the ventricle. So it's a hard decision to sort of figure out when to pull the trigger, because if you do it too early, they're in their 20s, you're going to need, 4 or 5 more interventions over time, unless someone comes up with something newer that lasts much longer than what we have. So that's been a pretty difficult decision from that standpoint. And that's why we use our, we have conference with our interventional colleagues and the surgical colleagues to get their perspectives of sort of what the right timing is, and come to a decision from an individual patient based on their trends over time, whatever diastolic function markers we can get. We may cath a little more frequently just to see what the pressures are, just doing a quick, right heart through IJ rather than a full cath to see if there's anything that we're missing or higher pressures than we see that we may not be able to see clinically from that standpoint.
And James, now do you look at the left ventricle a lot more to make your decisions about right ventricular intervention?
I look at the indices, the LV size as well on the MRIs that we do. we are often obsessed with just saying that anything less than LVE of 50% is then ventricular dysfunction. But you got to remember that these people are young, and a lot of them should actually have a left ventricular ejection fraction that is actually much higher, at least 55 and above. So anything that is lurking from 50 to 55 may well be abnormal as well. So that is something that we've got to come to terms with. What most adult cardiologists would say, that's fine, we'll leave that alone. But if you see any changes, echo also, you'll be able to pick up some diastolic dysfunction indices on tissue Doppler on the left side as well. And again, if there are subtle changes, not so easy to evaluate this for the RV, but easier, we have more experience in evaluating this for the LV. That also helps. And of course, the usual things that we do, the serial halters, as well as CPAT. So everything comes in to make that you have to make a call. So not just looking at all the usual RV parameters, but LV symptoms, I think would also help you in making that decision. I don't disagree with the cath, although it's harder to persuade them to do serial caths.
So this is a quick question to everyone. So now when you have replaced a pulmonary valve in a patient that to start off with, the right ventricle function was not optimal, it's a dilated right ventricle, functions borderline, you've gone in, you replaced the pulmonary valve, you get some degree of remodeling, maybe not much improvement in function, but of course the patient feels better, functional class is better. And then the valve starts to fail. How do you decide the redo of these patients when you're already starting off with a poorer LV function and already a dilated left ventricle? So James, we are running out of time. Just give me 1 or 2 answers. What would you do? How would you decide? Redo of the pulmonary valve in this patient.
We try not to do it open because that increases the rate. So we have all these percutaneous valves, or what my side is now doing a little bit more often is actually minimally invasive valve replacement. So it's a small cut here, and the surgeon goes in and out very quickly. And they put in the patient's usually out in 3 days. So that's if you don't want to put in an expensive percutaneous valve, then that's another reasonable approach.
So the what everybody wants to know is that one important criteria that we use to decide to go in and replace redo the pulmonary valve replacement. When you already have 4 parameters to start off with, what would you go with? Symptoms, arrhythmias, NT-proBNP, fibrosis, left ventricle, 1.
I don't think we can use one thing.
But the thing that will drive you all to say, okay, I have to start thinking about redoing this pulmonary valve in this patient that has not really done very well. Anything from the panelists, anyone, feel free to give your opinion.
For us, probably cath data or decrease in function are sort of the 2 things where if there's, we have previous cath data and we see that their pressures are getting higher than we expect based on their clinical evaluation, that may be one thing, but also definitely if there's decrease in function or a trend in decrease in function.
Okay, so now we'll talk about the aortic root before everyone gets upset with me. So the question here is that we do see this dilated aortic roots post-TOF repair, because here, especially in this region, many of the patients have the TOF repair done later. The PA, pulmonary atresia patients have shunts put in and repairs are done later. So generally, we are starting off with aortic roots that are larger than the norm. So the question is, do we have any evidence that by giving them some beta blockers or ARBs in this group, we can prevent the progression of the aortic root? 1. And 2, do we use an absolute value of 5.5 cm to consider intervening, or do we watch and see, surveillance? Because different patients behave differently. Sometimes once you've replaced the pulmonary valve, they actually don't really progress very much. So 2 questions. Can you prevent it from getting larger?
Yeah, so there's no large randomized studies like Marfan syndrome to see whether there's a decrease in aortic growth rate with ARBs or beta blocker, but I think we all do it regardless. You know, if we see a big aorta, we tend to sort of use beta blockers, and if they're a little bit hypertensive, we're much more aggressive in trying to get their blood pressure down from that standpoint. As far as the size criteria, you know, we've had a lot of patients that are up in that 5.5 range that we don't send them to surgery because they've been stable. And the assumption is they're just big aortas, but not thin walled, but sort of thicker walled, and the risk of dissection may be, you know, much, much lower than definitely Marfan syndrome, because there haven't been many studies reported. You know, I'm sure there's much more dissections. If we ask our colleagues, have you seen any that are not in the literature? So it's got to be more than 5, you know, in the world that's happened. So we tend to use the primary indication more of if they have severe aortic regurgitation and the aorta is big, and then we would sort of do it. But if they're stable, even some that are like 5.7 that have been stable for a decade, we wouldn't send them as a primary reason just for the aortic root itself or the ascending aorta. But if they have a progressive AI, then we would do that at the same time.
And you monitor that with just the echo? You're happy with the echo, or you have to accelerate and do more advanced imaging?
Yeah, we tried it as much as we can if we could get good images with echo. If not, we're pretty heavily use MRI, you know, for the right side of structure, so we get that as well. And then some patients that have pacemakers or, you know, other, you know, pulmonary atresia patients that may have coils or something, we may use CT scan. We try to use CT scan as little as possible just because of the radiation load.
I'm just wondering, Michael, I haven't gone to ACC, ACHD conferences for a while. The last poll that we did is as a group in, I think, 2006. We asked everybody there, have you seen an aortic dissection in your TOFs with dilated? And there was 0 back then. Anyone done this kind of straw poll to see? Because I'm still under the impression that it's very, very rare, you know, almost to the point that I'm happy to watch anyone with a large aortic root, even 55 to 60, if they have been stable, not increasing in size. And the only indication to do a Bentol would be for aortic regurgitation and the problems that come for the LV.
Right. We haven't seen that. I don't think we've done, I think just individually asking colleagues, have we seen this? And most of the time it's no. We've actually seen some patients with single ventricle Fontan that have had very enlarged aortas have had dissection. Probably more hearing about that than tetralogy.
So quick question to all the panel. So you have a patient that is going in for pulmonary valve replacement because of severe free flow pulmonary regurgitation. The patient has got severe aortic regurgitation, but the aortic root is about 5, maybe 5.3 cm. So would you do an aortic valve replacement and pulmonary valve replacement, or a Bentals and a pulmonary valve replacement, Michael?
Depends on the risk of the patient. So if it was a pretty low risk patient, we probably would. If it's a younger patient, we try to avoid reimplanting the coronaries if we could get away with not having to repair the root. And it's also a surgeon's call. So when they get in there, if it looks like, you know, it's going to take much, much longer or to dissect to get to the aortic side, they may decide not to replace the root and just do the valve. But it's very individualized in sort of what's each patient, how much adhesions they have from all the other previous operations. If it takes 2 hours to get in, they're less likely going to want to do, you know, full root replacement with reimplantation. And most people, if it's that bad, they don't want to ever come back into the chest. So they try to put a mechanical or whatever they can for the right side, that they can have multiple procedures without having to go back into the chest.
This, I think I will have to ask a little bit about pregnancy. I'm not sure, Leong, whether you'll allow me to say this, but pregnancy. So one, patients with free flow PR, maybe borderline RV volumes, function is reasonable, 40%. Would you allow the patient to get pregnant, or would you consider working the patient up, replace the primary valve, and then get pregnant? What are your thoughts, Michael, first, since you're on, and then we'll ask the other two panelists.
Sure. We tend to use exercise testing as a gauge of how well they can tolerate pregnancy. You know, we try to plan the pregnancy, for one thing, to have them either, if there aren't ARBs, to come off of that, and to plan with the maternal fetal medicine specialist that sees a lot of our patients. And then we try to get pre-pregnancy exercise tests to see how well they can tolerate the pregnancy. So even if they have pretty big right ventricle, severe PR, if they have pretty good exercise tolerance, they tend to tolerate pregnancy to term pretty well. We've had, a few patients where we'd recommended getting surgery, and then they end up having 3 more babies, and they're fine. Like, they're not any different than they were. They weren't having heart failure symptoms. Exercise capacity is roughly the same. If you talk to them how they're feeling, it's roughly the same. So I think a lot of things we do just based on the numbers, we really need to look at the patient to see how well they're doing, how well they feel, to gauge sort of when we should pull a trigger to do procedures. Because some of these patients where you put a pulmonary valve in, and by the time they want their last pregnancy, it may be close to time where the valve is falling apart. Now you have to do another procedure to get them through that. Whereas if you didn't do anything, they may have been fine up to that point if they were not having symptoms.
So James, valve replacement first or pregnancy?
Agree with Michael. So most patients actually with severe PR tolerate pregnancy phenomenally well. So if they have a normal exercise tolerance on CPAP, or rather no change for a long time, and they're functionally well, I just let them get pregnant. The only ones I worry are the ones with dilated aortic roots in pregnancy, and if they are 55, that would be a little bit worrying. We probably give them beta blockade in pregnancy if they aren't on at the moment already. So, and those are the ones I may actually quote a slightly higher risk, because spontaneous aortic dissection in the normal women is probably also higher. And I'm not completely sure that aortopathy or congenital heart disease or tetralogy of Fallot would be any different.
Chris, pregnant or valve replacement first?
Yes, from the guidelines stated that in patient that at risk for pregnant, so they only need to fulfill one criteria to be VR first, then they allow to pregnancy. So I think first is repair first, then they allow to pregnancy.
I think all good things come to an end. We are at the end of the 9:30 Leong. I think as much as I would like to continue, and I'm sure all the other participants are all very excited to ask more questions and to discuss this very exciting and common topic, yet very challenging. We have to end the symposium. Maybe this will open up more symposiums in the future. So before I end, I think the take-home message, if I may say, firstly, I think the most important thing is that not all patients are the same. So each patient should be reviewed individually. There are guidelines available in terms of primary valve replacement and in managing these patients for post-op repair, but guidelines are guidelines, and it should be used in a clinical context. And we have clearly heard from our speakers that there's multiple different parameters that we should use, from clinical assessment to exercise testing, biomarkers, MRI, and all the different modes of imaging. And I think also it's important to look at the context of the patient in terms of trending and follow up and changes that occur. We have learned not to ignore the left ventricle, the tricuspid valve. So these are all important parameters that we have to look at, and the aortic root as well as aortic regurgitation. So there are not very black and white answers for everyone here, but I think we have a lot of information that we have today heard and discussed. So taking all that into consideration, we should have a comprehensive review of our patient, come up with standard follow-through parameters or follow-up parameters that we should use, or standard SOPs that we should use in our own practice. And last but not least, every pregnancy should be a planned pregnancy. So please counsel the patients from the time they are teenagers to ensure that they discuss with us so that we can work them up and decide whether they can continue the pregnancy or have surgical intervention before that. And don't forget the arrhythmias, because sometimes this may come and hit you when you least expect it. So Holter review, exercise testing to look for arrhythmias, and also risk factors. So with that, please join me in thanking our 3 excellent esteemed speakers. And I would also like to thank the faculty, all of you participants who have been actively putting questions in the chat box. We really hope to have more of this combined Asian and our Western friends coming together and sharing expertise throughout the world and improving the care of our patients. And with that, thank you so much, everyone. Good night, and see you again next week. I think next week is even an interesting topic, congenitally corrected transposition. If we talk about TOF, this is the systemic right ventricle, a lot more challenging. So please join us next week and have a good evening. Thank you so much, everyone. And thank you, Singh, Dr. Michael, Singh, James, and Chris for your time. Thank you.
Thank you. This was awesome.
Yeah, I really
Thank you so
enjoyed the
much, Geeta.
session. Thank you so
Awesome.
much.
Thank you all.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye, everyone.
Bye. Hi, Geeta.
Yes,
Long time no see.
it was really nice to see you, James, Chris.
Yeah.
Very interesting topic, you know, so many gray areas. The more you know, the more you don't.